Welcome, everybody. I'm going to give folks just one more minute to log in, and then we will jump into our content for today. I'm also going to put into the chat a resource that, if you are a note taker, might be really helpful for you for today. Just a way of kind of structuring. There's going to be a lot of content and information that comes in kind of thrown at you today. So perhaps this resource may be a way for you to help kind of structure your thinking and identify some takeaways that you might be able to bring to your program. This is a resource that you can use for this week, and then hopefully you'll be attending next week's webinar focusing specifically on dementia, and this will be the same resource that you can use for that as well. So that being said, I'm going to go ahead and dive in. We have a lot of content, and I want to make sure that we have some time as well to have questions and answers and some discussion at the end of our presentation today as well. So welcome, everybody. For those who don't know me, my name is Caitlin. I am a senior program manager here with the National Institute for Medical Respite Care and the National Healthcare for the Homeless Council. I am also an occupational therapist by training, and really interested in how we look at and address cognition, especially among folks experiencing homelessness. It's something that can be a major barrier and challenge, but it doesn't have to be. And I think it's really important to have these conversations about how we can support folks who are thinking in all number of ways with all number of different cognitive skills. So let's dive in. So when we're talking about cognition, I want to provide just some basic information and definitions here. So cognitive information are the functions that are carried out by the brain. Cognition, if you can see here, there's at least 7 bullet points here about what makes up cognition. It is complex, it is complicated, and we could spend hours talking about even what cognition is and how all of these different factors work in somebody's brain. And so if you're feeling overwhelmed by this, or like, man, this is really challenging, that is fine. This is a really complicated topic that people devote their careers to studying. But what we really look at commonly is things like attention and memory. Speech is part of cognition, calculation ability to add, visual perception, knowing where things are in space, knowing where we are in space, praxis skills, which is around motor and movement. All of these different things are pieces of cognition, and thus can be impacted by when somebody has something impacting their cognition. So a simpler way about looking at this and thinking about this is the flow of cognition. And this can be a really helpful thing to go back to. So you don't necessarily, again, need to know what the definition is, but it's really important to know where somebody is struggling with their cognition is going to impact everything above it. So at the bottom, we have alertness. That's sort of our baseline cognitive skill. To be able to do anything else, we have to be alert. And it's not always a given, right? We have a bad night of sleep, we're feeling overwhelmed, we took a pain medication, right? We're not always alert. But to alertness is that base foundation to be able to use the rest of our cognitive skills. Following that, we have attention, which is concentration, focusing, listening in on what somebody is saying. We have to be alert to be able to pay attention. If we're alert and we're paying attention, then we're able to process information, encoding it, storing it, identifying what does this mean and what do I need to do with it. And if we can process information, then we are more likely to be able to remember that information. And I think it's really important to point this out because a lot of times what people notice is problems with memory. I can't remember to do anything. I can't remember what I need to do. I can't remember this phone number. I can't remember. That's something that's just sort of commonly people are really aware of. And so we might automatically think, oh, there's an issue with memory. However, if there's an issue with alertness, attention, information processing, then that's going to cause issues with memory. So it's not always memory. And I think that is sometimes we're addressing memory, but we aren't addressing those underlying skills. And that's maybe when sometimes strategies aren't helping. You can hand somebody a planner to write down their appointments, but if they're not focusing while you're doing it, they're not going to remember that that planner is there to help them. So really important, I think, to recognize that. And then finally, of these, the more complex skill is executive functioning, which really means our ability to start a task, sequence the steps, do the steps in the most appropriate order, stay focused on it while we're doing it, and finish it to completion. I think if you're reflecting on yourself, we can all think about times where executive functioning was worse than others, right? I discovered this morning I had not cleaned out my coffee pot, but I had cleaned out the coffee filter many weeks ago. Somewhere along the lines, my executive functioning erred, and it was probably an issue with attention. And so just thinking about that, when we're asking people to do really complex skills and steps, if again, along this chain of line, if something else is going on, we're not going to be successful. So And then I want to do some level setting around cognitive impairment, in part because it's such a broad word and it gets applied in so many different ways. And that's, I think, what makes some of this really more confusing. So when cognitive abilities are impaired, which is really what cognitive impairment is, that means they have trouble with cognitive processes. That's the global broad definition. There are sub-diagnoses underneath this, such as we see mild cognitive impairment is a formal diagnosis for somebody who's demonstrating early signs of dementia. But not everybody who displays cognitive impairment or mild cognitive impairment has dementia. It's a different clinical diagnostic criteria. That's confusing, but it's important to note if you're looking at somebody's chart and it says cognitive impairment, mild cognitive impairment, to try to do a little digging to figure out, was this diagnosed because they think they have dementia, or was it because they have a learning disability, right? That one diagnosis doesn't always tell you everything that you need to know. As you're going to learn in this webinar and our webinar next week, the difference matters in how you approach the person. Similarly, you might see terms cognitive dysfunction, which is when somebody's cognition is functioning below what we might expect in a normal age for their age group and learning level, and any of the areas of cognition that we've talked about. And so what affects our cognition? What causes cognitive dysfunction? It's a really long list here, but a lot of different medical and health concerns can impact them. We often commonly think about traumatic and acquired brain injury, developmental disabilities, certainly dementia, HIV, especially if people have gone for prolonged periods of not having it treated. Substance use, both active and a history of substance use, can impact cognition. Mental health symptoms, especially if they are more acute. Medical interventions and being in an ICU. So this is something we're seeing really commonly for folks who were hospitalized for COVID, and part of their long COVID is that brain fog piece of it. Other interventions, especially if you've been intubated or treated under really heavy sedation, can affect your cognition, sometimes more immediately and sometimes long term. And then chronic conditions. And I think this is really important to point out that folks with cardiovascular disease and diabetes do show cognitive decline earlier than the population of people who don't. And this is the general population. This is not folks who are experiencing homelessness. So really important to think about that, because then on the right-hand side, we have all of the things in our environment that impact cognition, right? So we're in Zoom. If we were in a classroom together, I would make everyone raise their hand who tells me that they function best when they're sleep deprived, right? Nobody does. So chronic sleep deprivation, poor sleep, not having food, not having the right food to make you feel well and energized, not having adequate housing, and then trauma and stress, which I identify as two separate things, right? We have a histories of trauma, perhaps an ongoing trauma, but there are also periods of time where we're experiencing more stress, and that can really contribute to impairment in cognition as well as low literacy. So I think if you're thinking of your caseloads and your different clients, you're probably thinking in your head, like, man, I have a few folks that check all of these boxes, right? And I think that's, again, why this conversation is so important, because folks do check all of these boxes. And that's why we need to think about, again, meeting them where they are based on their cognition. And I want to dive a little bit more into brain injury, in part because these are the more common areas of causes of cognitive impairment that we see. So an acquired brain injury is one that is not hereditary, congenital, or induced by birth trauma. It's one that happens after birth. So, and that doesn't involve a blow to the head. So acquired brain injury, we see that in things like stroke, again, infectious disease, meningitis is common, but COVID has become more common. People who have seizures, untreated seizures, tumors, and drug overdose. And I really want to point this one out because a drug overdose, the minutes unconscious from an overdose are really equivalent to the minutes somebody spends drowning in the pool. And that is why our harm reduction strategies around naloxone and equipping people to be able to revive folks who've had an overdose is so important, both for saving a life, but if we can act quickly, we can prevent more long-term cognitive damage. Important to, again, remember and think about what might be happening for somebody who's had multiple overdoses and what that is continuing to do with their brain, in addition to maybe current substance use. So I think that's more common in our population than others, and really important to point out and think about maybe why we might screen somebody who's had a series of overdoses. Alternatively, traumatic brain injury is the other type of brain injury. Those are things that I think are more common for people to think about. The top three are really, I think, more frequent in our population as well. Folks who have falls, especially older adults, assaults, and motor vehicle accidents. And it's, again, really important, even if the physical symptoms seem more prevalent from a motor vehicle accident, there's likely some cognitive effects, even with a brief loss of conscious. So another one to point out again is abuse and interpersonal violence really increases somebody's risk of having sustained a brain injury and not having it treated. So these folks might be coming into your program, and in medical respite care, that might not be the primary reason that they're there, but all of these things might be hanging out in the background, and that's going to affect their ability to engage in care and engage with the program. So as we see, any of these effects on the brain can result in difficulty with concentration, attention, social interactions, judgment and decision-making, following instructions, multitasking, learning new things. So again, thinking about how often we are requiring or thinking about people to do that within respite, engaging socially with people, figuring out a solution to a problem, learning to do something new that's multi-step, that can be really challenging with cognitive impairment. On the right-hand side is things that we might say to describe those people. They're disorganized. They don't follow through. They just repeat the same mistakes over and over again. They're stubborn. They jump to conclusions. And from a trauma-informed perspective, I want us to train our language differently because it's not personality. It's not necessarily intentional with folks. A lot of times it's something cognitive, and these are things that are showing as a result of developing a coping strategy or as a result of the injury to the brain. So trying to think about, how do we reframe this? Somebody keeps repeating the same mistakes again. They're having trouble learning, right? This person is stubborn. This person needs more individualized coaching. This person needs more explanations about why they need to do something, right? Thinking about the action of what the person needs as opposed to those negative behaviors. Because when we start assigning these and documenting these to folks, it is harder for them to get good care, right? We all know how that feels. We open a chart and it's like, oh, this person is stubborn. Oh, they do, they don't follow through on care. They're non-compliant. And immediately, I think an energy changes. And so thinking about how we're talking about these things can really help across the team figure out what we need to do to support people. It's also important to note that cognition can impact physical function. So if the brain is affected, these cognitive and thinking skills might be affected, but the brain also directs our movement and motor actions. And it can affect how somebody plans and is able to follow through on a movement activity. People who sort of seem to be stuck, they know they want to stand up, but they're just kind of sitting there and they're not pushing up, right? That could be as a result of cognitive impairment and brain injury. And additionally, they might have a hard time learning new ways to move and to do things. We might see this again commonly in respite with folks who are learning to use mobility devices and seem to be kind of struggling with remembering to do it safely. Oftentimes there might be an underlying cognitive issue, maybe even just alertness, that is limiting their ability to learn how to do that in a new way. Similarly, we have emotional and behavioral regulation. There is a ton of overlap between these two areas of our brains. Areas that control cognition also regulate emotions and behavior. So if somebody has a brain injury and that area of the brain is affected, we might see those cognitive things, but we also might see emotional and behavioral changes. Similarly, if people notice that their cognitive skills are not working well, they get frustrated, they get mad, they start to get anxious, which is really understandable, right? Why can't I remember how to do this? I don't go new places. I've heard that one before from clients because there's anxiety about getting lost and not being able to figure out where you're supposed to go. And so it's really important to note that if somebody is having difficulty with emotional regulation, right? If somebody's wound up, if they're agitated, if they're mad, if they're feeling stressed, it's going to be really hard to use your cognitive skills. And that's true for all of us across the board, but especially challenging if you have difficulty bringing yourself back down and centering. And then there's a few other things, again, that can affect cognition. We talked about sleep, acuity of mental health symptoms. So mental health diagnoses don't always mean that somebody has cognitive impairment, but if they are more active, if somebody is in a really active depressive state or psychotic state, that is going to affect their cognitive skills, but it might go away if that's treated. Level of stress and emotional distress at that moment. It's also important to note many medications and side effects can affect cognition, especially alertness, or again, those feelings of brain fog that might limit skill building. And then pain, whether it's medications for pain or active pain, can really affect our ability to pay attention. And why does this matter to our populations? Why are we talking about it in medical respite care? We know that these populations of people are significantly higher risk for experiencing a brain injury. So folks experiencing homelessness, victims of domestic violence or interpersonal violence, folks who are incarcerated or have engaged with the criminal justice system, individuals who are living in poverty, and veterans, especially those who are dishonorably discharged. So again, when we're thinking about the people who come into our programs, most of the time somebody doesn't just fall into one of those circles. There's a lot of different overlapping histories, and that then just increases the risk that they might have sustained a brain injury at some point. And the data supports this. We know that increased odds of a history of brain injury with a loss of consciousness, so the person blacked out, is associated with. So people have increased risk for mental health and substance use diagnoses, except psychosis, a history of suicide attempts and recent suicidality, which I think there's a lot of overlap between brain injury and suicide risk. So something really important to note and think about as we're addressing behavioral health needs, as well as having migraines and experiencing epilepsy. Additionally, anybody who's had folks experiencing homelessness who've experienced a TBI with loss of consciousness are also more likely to be in contact with the criminal justice system, often as a result of those cognitive impacts around judgment and problem solving and navigating resources. For the medical respite kind of focus, it's also important to note this group of people is more likely to go to the emergency room. They're also more likely to report unmet healthcare needs, even though they're more likely to access a regular doctor, because there's so much, this was hypothesized to be so much that's going on with the person, so many challenges, and having difficulty executing some of those things. But somebody with a brain injury sees their primary care and they might get referred to 5 different places. They might not be able to do that. And so those needs are continuing to be unmet. So again, really important to kind of note these kernels as we're thinking about, reduction in ER visits is really important to a lot of respite programs. How do we need to tailor and work with folks with cognitive impairment around that? Relating this again, linking this into medical respite. Why are we talking about this? In addition to just it being folks experiencing homelessness, people might be coming to the respite program with a new onset of cognitive impairment, resulting because of the event that brought them to the hospital, a stroke, a motor vehicle accident, being in the ICU, and it might be a recent diagnosis and might be connected to whatever they're referred for respite for. So people are navigating it for the first time. Additionally, it's important to note that cognitive impairment can get in the way of activities needed for recovery. This is the tricky part about cognition and brain injury. It's not always, we can't say this person had a brain injury, so they're not going to be able to do it, but it is more likely, and it's important to know kind of what each individual person's response is. But it can make it hard to go to appointments, following medical instructions, taking medications, completing paperwork. It can get really overwhelming. All of these are really key aspects of the care coordination process in respite. And medical respite, again, as we mentioned, really serves the population of people who are most affected by this. And oftentimes they might not have had an opportunity for rehabilitation to build strategies around their cognitive impairment. It might not have been detected or diagnosed yet because of housing instability. And this might be an opportunity to link them with some resources they might be eligible for. It's also really important to note that our population is facing aging and aging-related health concerns earlier than the general population. So there might be some of that age-related cognitive decline happening in folks who are 45, 50, 55, as opposed to 65, 70. So just some things to keep in mind. Here's why we're here and really why we're talking about this. And why this becomes barriers in medical respite. People might have challenges following the rules. They might have a hard time engaging in structured group activities. They might be really overwhelmed following schedules and making a lot of the same mistakes that really then result in loss of services. And this is because, again, these skills that are affected, things like managing time and memory, groups are really challenging for people who have issues with attention. And that's something that often people describe as being really overwhelming. They're not able to problem solve. So if their SSI caseworker says, well, come here at 2, and they have a doctor's appointment at 2:30, they might not recognize that that's an issue and they're not going to make both. And they might miss one or the other without planning and asking for help to figure that out. They also are going to focus on safety, as many individuals do. And then they're going to have some unmet health needs. And they might not be able to describe what that is. Again, access different referrals or resources people are sent to, and then are more likely to experience some re-traumatization, especially if they're discharged from programs or services early, and so on. So what do we do about it? This is the bulk of the rest of our conversation today, is really thinking about what are some things that we can do in medical respite that are going to be really helpful. So a few notes. These strategies that I'm presenting today are really most effective where the person has capacity to learn. That is everybody with cognitive impairment and a head injury, unless they have dementia. Everybody has capacity to learn. It might take more time. It might take more support. It might take more repetition, but people can learn new skills. There used to be sort of this misnomer that if you didn't improve in 6 months, that was the end of it. That's what your skills were. And that is not the case, and the science is supporting that. But we have to know that it's not going to be immediate. If the person has dementia, these strategies are not going to be as helpful. And that is why we're having a whole separate webinar next week that I hope you're able to join to really think about how we can support folks with dementia, because it's different, because there is not capacity to learn. So we've divided these into 3 buckets, which is sort of related to the handout that if you received that, there are sort of 3 major ways that we can support folks with cognitive impairment. We can focus on building alliances. We can build compensatory routines. So there's a lot in the research around cognitive remediation, very limited within folks experiencing homelessness. We are not focusing on that today. We're not talking about remediation. We're talking about strategies that people can use to get things done in their everyday lives. So not doing computer programmings and word repetition, just things that are going to help us get through our day. And then as a respite program, how can we develop a supportive environment for people with cognitive impairment? And I want to point out, if you're starting to be like, oh man, we don't do anything, you do. Trauma-informed care has significant overlap with the recommended supports and strategies for people with cognitive impairment. Almost word for word, you can do this, right? Assume that there's a potential history of impacted cognition. Understand that the prevalence is high and that it might not be recognized. Deliver care that compensates for the existence of this. And recognizing that progress and success are available with the right supports, very similar to how we deliver trauma-informed care. If you're doing that, you're already on the right track, because those principles align so well with providing services for people with cognitive impairment. It's client-centered, and it's understanding what people's individual needs are. Needs just might look a little different. Similarly, harm reduction is another really helpful approach that if your program is able to do this, again, really supports, because here we have a person at the center who's experiencing all of these different things at all of the same time, right? And anytime we add a requirement for services, we limit people's ability to get their basic needs, ability to access self-care, and really then ability to change. So when we recognize that there's all of these things happening at the same time and that they're impacting each other and manifesting in decisions the person is making, if we provide a safe space to make those mistakes, to engage with care and build that relationship, people are going to see more success that they're not going to get in other places. So what does building an alliance look like? I think one of the first things, and again, if you're a social worker therapist, you're gonna be like, yes, of course, Caitlin, of course we would do this. But before you begin an interaction with somebody, just check in on how everybody is feeling, right? If the person is not alert, if the person is feeling mentally disorganized or overwhelmed, you want to make sure you know that before you even dive into any of these strategies or learning new things, right? And that very basic strategy, that deep breathing that we all know is so essential, right? Taking a deep breath, listening to a song that maybe is calming for the person if they're sort of wound up, or maybe alerting for the person if they're feeling sort of low. But taking that moment to check in is going to increase the ability to use any sort of cognitive skills or strategy. And it improves everybody's ability to use cognitive skills as a busy provider in a medical respite program and as a consumer. It's also important to identify communication. Do our communication styles match, right? Do I understand what my client is asking? Sometimes people can be very tangential, very grandiose, sort of speaking in large, and it's like, do you know what the ask is, right? Do I understand that? And does the client understand what I'm saying? Are they able to remember it? What's going to help them remember? And what strategies do they already use? People have learned to compensate for many years with a lot of these things and might have some things that they're already know and already do really quite well. And it's important to build on those as opposed to introducing something new. So really just assessing, like after an interaction, like how did that go? Did I feel like we communicated well? And assessing that and seeing what might need to be changed. Additionally, especially if there's some emotional and behavioral regulation issues, again, this is really, I think, important just in trauma-informed care in general, making sure that we're consistent and realistic with expectations, and just know that there's the potential for emotional responses, but that's where that de-escalation training is really important to be able to handle that in a calm way that doesn't impact the person's ability to engage in services. And working with the person to identify what their triggers are. They might not know, they might not realize a loud room causes them to feel irritable and explode at people. So noticing what those situations are and helping them identify them, and then thinking about strategies that might be helpful for them to be able to manage that. Additionally, with goal setting, folks with brain injury and cognitive impairment can have a really hard time setting goals. And so it's really helpful, I think, as a provider to help set really structured goals. SMART goals is one example, but there are other methods to help the person understand what is to be done, right? Like tangible focus. Here's what we're going to do, and helping link that to what the overarching goal is, because they may not remember. So if they're going, why are you sending me to go get my birth certificate? I told you that I want to work on housing. You might have to remind them, you can't apply for housing until we have documentation, and we need that birth certificate to be able to do that. And you might need to repeat that over and over again. But when we know why that's happening, it makes it a little easier to use those strategies. And there's some ways that we can check comprehension. So saying, do you understand is not a good question to check comprehension, because oftentimes, because of the provider person dynamic, they'll say yes. They'll say, okay, yep, I got it, and have no idea what they're supposed to go and do. So using different phrases. Can you tell me what you think you need to do next? I want to make sure that I was clear. Can you tell me what you understood? Show me what medicine you need to take. What is your plan for leaving here? Can you summarize what we talked about? Using that helps you identify where the gaps in knowledge are for the person, and maybe saying, oh, you missed a couple of things. Can we write it down? Maybe can we use a notebook, and introducing some strategies there. But that's going to help you know what the person might be struggling to remember, and knowing maybe they need a little more follow-up on that. Maybe you're going to have to check in with them on a day and say, hey, did you go down here and do this? And they say, oh, no. And so checking that comprehension, one, helps reinforce what you talked about and helps identify what strategies you might need to use to help them. Additionally, so we're at building compensatory routines. So this is, again, there's a lot of strategies in here. There's a million different strategies that you can use. I really picked today ones that I feel are most supportive of the care coordination process, engaging in community resources and getting things done. There's a ton you can use for attention and memory, and there's some resources linked at the end of this that go into those. But these introduced today are really ones that I think will help facilitate people in that recovery process and respite. So the first one is prioritizing, and called the brain dump. And it's a really actually a helpful strategy for any of us. But I tell people to sort of picture themselves like taking their brain off their neck and like just shaking it onto a piece of paper. What is everything that is on your mind? What is circling? What is floating? What is distracting you at this moment in time? Get everything out. Take 5 to 10 minutes to do it. If the person has trouble with language or processing or writing, you might need to write it for them. But again, giving them that time to really just like, here's everything now, here's everything later. And what is it that I'm thinking about? Using that list and really looking at the written tangibles, working with the person to say, what's most important? Where do I really need to focus? And what is the priority? Sometimes people need help with that categorization. I didn't say that right. But using labels such as have to do, right? These are things that are non-negotiable. This is what has to happen every day. I have to take my meds every single day. I have to brush my teeth every single day. Versus things that are should do, like this is important, but it can wait a couple of days if I run out of time today. Things like I need to schedule this follow-up appointment. Things in the should to-do list can move to the have to do, right? If in 2 days we haven't called for that follow-up appointment, suddenly that moves up in the priority. And then what to do. Those are the things that are not priority, but would be really nice to get done. And again, those things can shift depending on what's accomplished and tackled. The person can then use that list, both the brain dump, so they know that they've talked about everything they need to talk about, and then the identified priorities, the next steps, and they can reference that, and you can help them reference that so that they know what to do based on your conversations or your care plan. Additionally, you can assist folks with problem solving. Again, this is really challenging for a lot of people with cognitive impairment, and they might need help thinking ahead about what might happen. What are the potential options of a particular situation? They might not be able to generate that. They might be able to think of one, but they might not be able to think of multiple. What are you going to do if the bus doesn't come? Well, I didn't think about that. The bus always comes. Sometimes it doesn't. What are you going to do when that happens? Who can you call? How can you get there? And then once you've identified those problems, helping them identify solutions. Again, they might have trouble identifying what those solutions are. So you might be prepared to give a couple, only promise and suggest what you're able to follow through on. If the bus doesn't come, give me a call and I'll call an Uber, right? Only offer that as a solution if that's something that you're actually feasibly able to do. And then use step-by-step teaching to give specific instructions for people so that they're not having to guess. If they have trouble with problem solving, they're not going to be able to just sort of generate what needs to come next. They're going to need specific strategies for specific actions. So I'm going to dive into that here. Identify the steps before doing anything, right? So this is how we can do step-by-step instructions in a helpful way. For people, you can write down the steps that you need to do before they get started. So I always think about checking blood sugar with a glucometer is really complicated, right? So walking through all of the steps with the person one by one before they do it, writing it down if they have a list, or going through it verbally, whatever their preference is. Then the person completes the step one at a time. You're either going to tell them, use your list, what's your list say next to do, or you're going to give them a verbal cue, right? Saying something to them. Okay, next you take out the strip and put it in your glucometer, right? Telling them step by step. You want to minimize guessing because people with cognitive impairment might remember the information wrong if you let them guess. So you want to prevent them from doing it incorrectly, especially really important things around meds. And then the clients can repeat the steps out loud to themselves. Again, if you say it or you have them read it, having them say it out loud is another way to facilitate learning and use of the brain. And breaking these steps into sometimes small reminders. If it's a really big task, it might be something that happens over multiple days or weeks, but helping the person identify, here's what we're going to do this week and next week, and then the week after that. You don't have to do this all on your own. If it's basic sort of routine daily life things, everything is step-by-step on WikiHow. Fantastic resource, look it up. Teach your clients to look it up if they are smartphone users, because it really does give tangible step-by-step for things that you don't have to invent every single time. And then the next piece of this is really generalizing skills. We want people to adopt skills, but we also want them to use them in new contexts or situations. And this is where it gets, again, really challenging with cognitive impairment. Somebody might get really good at writing down information after they meet with you, but they might not write down any information after they meet with other providers. That's when you can work with them to identify, hey, it seemed to work really well for you that you wrote things down after we met today. Where do you think that might also be helpful? You can see if they can come up with that. If not, you can prompt them. I think that would be really helpful to do that when you see your primary care provider, so you know what's happening next. I think this might be really helpful when you talk to your community case manager, so that you remember what to tell me, right? Prompting the person, and then having them practice, giving them homework to do that. Next time you go to an appointment, bring your notebook with you and write down a summary at the end of the conversation. You might need to remind them to do that the first couple of times. And then once they do it, reflect. How did that feel? Did that work for you? Is that something you want to continue? Doing that reflective action with them after using a strategy is really helpful for helping the person recognize this is helpful here, so I can try it here. And they're going to be able to do it in multiple situations then. The more they do it, the more they're going to be able to continue to do it without as much prompting, which is important because folks are not in medical respite forever, right? We want them to use these strategies that they're learning in respite once they leave our program. So taking the time to talk with them and reflect on what works, what doesn't work, and supporting them in being able to do that in many contexts. So it's important to remember, again, especially with brain injury, that progress can be inconsistent and unpredictable. Somebody can do really well with a strategy for like a week, and then the next week, it's like you've never talked about it. Go back and remember all of those different things that can affect cognition, right? At that point in time, maybe the person's in more pain, maybe they're not sleeping as well, maybe they got a stressful phone call that they're thinking about. So just be ready that things are going to take a little bit of time, that people can eventually learn them. Especially people with an acquired brain injury and traumatic brain injury, there's going to be stamina and fatigue, cognitive fatigue, right? Their brain is going to be tired from doing all of this work. So we can't dump all of these strategies on somebody at one particular time. It's better to pick one or two to try and support the person in using so that they don't get tired and overwhelmed. And again, because medical respite is not long-term for most folks, note that transitions can be difficult. They're going to be, you might see some decline as they transition into your program, and there might be some decline as they're preparing to transition out, right? That's a normal stressor. And you might see declines in behavior, but also in cognitive skills. So just remember that and note that it's not all in vain, but there are other things factored in that are going to be affecting the person. So next, we're going to talk through external supports. These are things that people can do in their environment. So the strategies that we've talked about, right, are things that we do, kind of paper pencil related. External supports are things that we put up to help prompt us when we're in different spaces. When we're doing external supports, again, talk with the client, build rapport. What works for you? Do you like Post-it notes up on your door? Do you like setting alarms? Do you like organizing your stuff? What do you need help with to do? Because we don't want to just pick a strategy for somebody. We want to engage with them and figure out what's going to work best for them. And just note, just like any new learning, the person might need some cueing to use it initially. Oh, did you look at your reminders above your bed? Did you look at the calendar to see what was going to happen next? And have them go look and do it so that they learn that they are able to do that and don't have to ask you. So I'm going to go through some of what these basic external strategies are. Visual reminders. Again, things like Post-it note, labeling things, like the drawers here so people can find stuff easily. I had a client who liked a stop sign at the entrance and exit to his kitchen. So he remembered to stop and turn around and make sure he turned everything off before he left. It needs to be meaningful for the person. So a stop sign doesn't mean that for everybody. But also don't overdo it. Not everything should go on a Post-it note because eventually you're going to have a wall of Post-it notes and it's going to be hard to decipher what's needed. Really pick the priority things. A Post-it note by the bed. Take your meds, bring your glasses, right? Those are really crucial things a person might want to remember to do. And then again, we have checklists. So this again can be really routine things, which pictured here, somebody made a daily routine to help them remember everything they needed to do in the morning. It can be simple. This one's pretty basic. It can also be complex. Again, if we're doing more complicated things like checking blood sugar levels, and should be available where the person can easily see them. Nobody should put their checklist in a drawer next to their bed because then they have to remember that it's there and open the drawer and pull it out and use it. Most of us are not going to do that, myself included. Put it in a visual place where the person's going to access it and see it, and where they're more likely to use it, in the bathroom, by the bed, in their wallet, whatever that might be. And supporting the person in getting organized. Organization can be really hard and complicated, again, for people with brain injury because of the decision-making that's affected and judgment and not knowing, like, is this important? Should I keep it? I can't make categories of things. I don't know how to sort things together. So they might need some support to do that, but figuring out easy, simple ways for them to store items easily to access that are really important. So one client I worked with, he had a lockbox under his bed and he had trouble getting out of the door in the morning. So that drawer was the key things that he needed to take out, shove in his backpack every morning. They went back there when he got there at night, he could lock them up, and that's what he took when he left during the day. And that's the only thing that went in there. So it didn't get cluttered or disorganized, and he didn't have to go looking for things to leave on time in the morning. Simple things like folders and notebooks can be really helpful. Storing like items together. Some people don't necessarily intuitively do this, but are my shirts together? Are my pants together? So it's easier for me to get dressed on time in the morning. Are my meds all together? Are my morning meds together? Are my nighttime meds together? Just really helping people figure out what makes sense to keep together for them, and minimizing clutter. And again, this can be challenging, especially if folks are bringing all of their belongings into their respite program, but thinking about creative solutions, so storage lockers or bins or things that people can use to minimize clutter. That helps cognitive skills, but that also helps reduce risk of falls. So it's kind of a double win there. And then using natural routines. This is, again, another really good one. Just pair something together that you already do. Take your medication when you brush your teeth. I'm already by the sink. There's water running. I've got my stuff together. I'm going to brush my teeth, take my meds, rinse my mouth, and I'll be done and on my way, right? Really simple to do that. Things that are already within the person's routine. I have a lot of clients that are like, I get paid and I pay my bills immediately, so I don't forget any of them. That's a natural routine strategy. What is the person already doing consistently, and how can you add just one thing onto that that's really important for them to do to build it into their routine? And then minimizing distractions. Again, this can be challenging depending on the physical space of your respite program. But is there a quiet place where people can go to fill out paperwork? Is there a quiet place to meet with providers to talk about complicated things? Just really thinking about that. And you as a provider, with some folks, especially who get really distracted, can I take my phone off the hook for this conversation? Sometimes you can't, but how do I minimize the impact of noise happening outside or in the space that we're in? Telling the client to turn off their phone for the session so that you can focus, and making sure that things are not buzzing and going off. Really thinking about how you can do that, maybe not all the time for people, but to help get some of these essential things done. And then also decreasing visual information. This is a really helpful one for paperwork. Again, people get really overwhelmed by that. And all of us have seen the disability application paperwork, and it gives me a headache just to look at it. I'm sure everybody else too. If you're somebody with cognitive impairment, that's really overwhelming. So, on the right, we have, here's a list of instructions to change a light bulb. That looks really complicated, right? If we just add, in real life, this would be a piece of paper or a note card covering up those steps, right? All of a sudden, it seems a little bit more doable. Well, I can read 2 sentences, right? And as you move down, just moving that piece of paper, that note card down, so that they're only focusing on one section at a time. And that's going to prevent that cognitive fatigue, feeling overwhelmed, frustration tolerance, and people going, I can't do this paperwork with you today. I'm not in the mood for it, right? I think we've all heard that. If we minimize that feeling of overwhelm, people will be more likely to sit with us and be able to do it. And it's also important to remember, when people have dual things going on with physical needs and cognitive skills, people who are doing who need physical adaptations might need extra cueing when they also have cognitive impairment. They might need step-by-step instructions for movement, lock your wheelchair brakes, lean forward, put your hands on the walker, now push up, because their brain isn't able to sequence those steps more effectively. They might need extra time to process directions. So try not to rush. Okay, well, just push up and stand up. That's going to be really overwhelming, doing step by step and allowing their body to respond to the instruction that you're giving them. You might need to show them first so they can see, how is the body supposed to move to do that? And they might need more visual cues or environmental cues to prompt that. Like a big stop sign, it's like lock your wheelchair brakes, right? That's a big one, is making sure people lock their wheelchair brakes. So putting up a visual cue to help people remember to do that. Somebody who has affected cognition and emotional regulation, they're going to need more support probably to use cueing strategies and things that are going to help them calm or stay regulated. They also might need step-by-step instructions to manage frustration. They maybe, again, are going to need extra time or to not feel rushed to manage that anxiety piece of it, and might, again, need help problem-solving solutions, seeing the alternative and understanding that they have options and what they can do. And they might need help developing some structure, especially in their routines. And then finally, how do we create a supportive environment? And this is really more bigger picture. And these are conversations that might involve more of our program managers and staff that way. But things to consider: do I have a supportive environment? So for someone with cognitive impairment, can somebody find easily the information they need? Can they easily find someone who can answer a question? Do our materials meet literacy and health literacy guidelines? It's a really good way to immediately modify for cognitive impairment. And when people consistently report something as difficult, ineffective, or a process that doesn't work, what do we do about it? How are we changing that for our folks? So some really basic things, and I'm not going to dive too much into this, in part because we do have a webinar on creating a trauma-informed environment, which goes over a lot of these different strategies. But some really key things is, do I have clear signage? Can people find the laundry room? Can people find their case manager's office? Do people know where to go to eat? Having it really clear and visible so people can navigate more independently. Key information in central locations. Is there a bulletin board? Is there a central schedule? Or does everybody have a schedule posted on their door? Again, depending on the structure of your space, but can people easily figure out what time lunch is served so that they don't miss it? That's a huge trigger and frustration for people's time management issues when they miss meals, right? And do we have staff people who can answer questions, right? When you are an overworked case manager trying to get a lot of stuff done, the last thing you want is somebody knocking on your door all day, right? And that's when you get frustrated, and it makes it feel more frustrating to interact with folks who need more of those resources. So, is there a way to designate someone who's available, a desk person, or having open office hours where people know they can come and ask questions can be really helpful. And again, providing reminders in whatever way that might be around when things are happening, when medical providers might be on site, when people have appointments, and supporting people. Do I have things that I can give clients? Do I have Post-it notes and notebooks and folders that I can give them to be able to use these strategies? And it's really important to remember to talk to the people in your program. What's helpful? What should we have? What do we need? If you can develop a consumer advisory board, that's great. But you can also just have conversations with people around what was helpful for you, what would be helpful, what can we have on hand to support that. Also thinking about the rigidity of rules and what that means. Do we discharge people if they've missed multiple medical appointments, or do we have a process for understanding what might be happening when that happens? And is the person truly forgetting because there's underlying cognitive stuff going on. And just making sure that you have time to work with your team to do that care coordination. Again, it's really, everybody's kind of understaffed and overworked, and that can be really challenging. But touching base with each other can be so helpful to make sure everybody's using the same strategies in the same way and saying, hey, that worked really well for me. Maybe try this next time. And so just thinking through how do we start, right? I just dumped a bunch of different options on all of you today. And you're probably going, oh, Caitlin, this is the opposite of, like, I have cognitive fatigue and overload, right? Breaking it down and thinking about how can we start to integrate these more routinely into our program, thinking about who's going to be the people who might provide some of these accommodations, who can do more of the organizational changes, like making sure people have time to meet with their care team or put up signs in the building, and identifying where are we going to start. Maybe we're going to look at the environment first and see if we can improve that. And then maybe we're going to learn and practice some of those individual strategies more. There's no wrong way, right? It's what's going to fit with you in your program and what feels accessible at this point. This is an overly complicated slide, but this is really just showing, depending on your model of medical respite care, if you're familiar with our models, who might be able to do what. Providers who are able to do care coordination can use these strategies with their clients to help the health management and self-management piece. Community health workers and peer supports are such essential staff to go with people to help them use these strategies on hand. You're probably already doing it without even realizing it, but thinking about it more intentionally with folks. If you have some clinical support, right, think about how are we delivering health education, right? If you're an RN, teaching people how to take their medications, how do I make sure that I'm doing this in a way the person can understand and remember? And then communicating, if you don't have providers on site, communicating with their external providers, like, hey, I think there's something bigger going on. Can we screen for a history of brain injury? Can we screen for cognitive impairment? And then making sure those providers document it, because that's how people might be able to access resources. And that helps communicate with providers across the board that a different approach is needed. If you're on site and you're a clinical provider and you're housed within the medical respite program, you yourself can do some of this assessment, and you can think about the effect of cognition when you're prescribing medications. If we know the person has cognitive impairment already, how do we need to prescribe something differently so that doesn't worsen that? And for everybody, get additional supports as needed. Refer out for further medical assessment as needed. Maybe connect the person with OT, with speech, with neuropsych or psychology if that's available. And some community-based support programs, things that are focused on folks with brain injury, can be really helpful. And then thinking about behavioral health care, again, I brought this in here because oftentimes doing medicated assisted treatment, or MAT, has a lot of rules around it. People can't miss appointments, they can't miss dosing, they have to report things. People with cognitive impairment have a lot of challenges keeping up with those rules, and it's not about avoiding it, it's more about just not being able to execute it. So as a behavioral health support, again, helping people use strategies when they're engaging in these programs in behavioral health care. And then on the other hand, really thinking about on-site as a behavioral health provider, if you have that, am I trained in the most effective interventions for people with cognitive impairment? There are ones that are more effective than others for people of this population. Again, assessing for cognition as appropriate and thinking about how that's affecting their engagement with other outside services. And then anybody can do environmental strategies, but it's just going to take the program investing in the time and space and allowing people to be able to do that in an effective way. So that's the end of the presentation. I'm going to invite folks to put questions or comments into the chat. The webinar and the slides will be posted in a couple of weeks. So there are resources that I'm not going to talk through here. They're all linked that dive much, much deeper into all of some of these different topics. So just know that they're there, but I'm not going to talk through them today because you'll be able to access those. So I'm going to pause and see if folks have questions, comments. Yeah, we have about 10-ish minutes for discussion. And I'll also point out that Stephen shared our link to the recorded webinar around trauma-informed environments in medical respite. So that, again, dives deeper into making those environmental modifications as well. I overwhelmed you all, I knew it.
What is the most common used screening tool for cognitive impairment? Is it like the mini mental status exam, or is it the MOCA?
That's a great question. So the mini mental status exam is really only most effective if there's potential for immediate cognitive decline related to a medical intervention. So that's often why they do it in the hospital pre and post, just to make sure it's mental status, right? What is my mental status right now? It doesn't necessarily give enough information to be diagnostic for ongoing cognitive impairment. The MOCA is very frequently used. It especially is used for identifying mild cognitive impairment for people showing signs of dementia. What I will say is that it's not been extensively tested on people experiencing homelessness, shocker. And it has a cutoff range of 26. So people with lower education levels will score lower on it and might show cognitive impairment when it's more of a literacy issue. There's some data to show that a cutoff of 23 is more accurate for people who did not complete high school. So that's in the literature, but it's not, if you do the MOCA training, it's not recommended. The other barrier with the MOCA is because it was used on a certain president a few years ago to test their cognitive status. You now have to pay for the training to do it because people were kind of wildly using it. But it can be a really helpful tool to get an initial diagnosis in there and to help people be referred maybe for more intensive services. Probably the best bet is getting folks into neuropsych, which I know is an incredible challenge and there's a ton of backup, but doing that initially can be really helpful. And then if you have, say, behavioral health staff on site, some of them can do additional training to do more cognitive testing. It just kind of depends on what your program looks like. There's also the SLUMS, which is the St. Louis University mental status exam. I think very similar to the MOCA and is still free. So you can also use that alternatively. The short answer, there's not a great tool, but it's good to start with something to know where somebody's at. The MOCA is nice because it kind of helps you identify like, oh, attention is really shot. Like, no wonder we are not getting very far with memory. It is helpful in identifying the different categories where somebody might be having trouble. Who can administer MOCA? Great question. A lot of different staff can do it. Social workers can do it, neuropsych, medical providers, any prescribing or diagnosing provider can do it. Rehabilitation staff can do it, such as an OT or a speech, but they, within their licensure, can't add a diagnosis. So if somebody else does it, they need to send it to the medical provider who can then add it to their problem list if you need that documented. And I can link the MOCA there if folks are interested. I think it's $250 per person, and then they have a rate if you're going to train a bunch of people. Any other questions? Feel free to come off mute or to throw them in the chat, whatever way you feel more comfortable. A lot to absorb. What I will say is, as you're delving through all of this, look through the slides, look through the resources that are linked in the slides itself. And I hope that you will join us next week for our webinar on addressing dementia. As I mentioned, it's a different set of skills and strategies, and we have a subject matter expert, so you don't have to listen to me presenting on this. And again, hopefully giving you all some really good takeaways for your programs should you have folks entering into that. So I would say, Brandon, if you're available, we have a short survey since we have a few extra minutes. If we can launch the survey, if folks don't mind taking that. And then once you've completed the survey, I will say goodbye and thank you so much for joining us today.